Morning, Chuck.
Good morning, Dr. Neal. How you doing? Can you hear me?
Doing fine. Can you hear me okay?
Yes, I hope that you're not hearing any jackhammering in the background. They're working on my home here. My wife's trying to whatever wives do,
Yeah. I understand. We're due to have our lawn mowed, and I just hope that doesn't happen. Oh, Lord. Lots going on in the world. It's on fire. Now, what happened? Join meeting. I'm spending a lot of time with your brother on meetings for the pharmacy committee.
Oh, Joel?
Yes, with Joel. It's kind of interesting. I kind of feel like an add-on as a physician who hasn't treated a lot of things they're dealing with, which is, treatment for AIDS and smoking. And it's kind of interesting though.
Yeah, my pharmacy colleagues have the kind of their own, they have their own worldview. It's Yeah. Joel won a really nice award from the American Academy of APHA, American Pharmaceutical Association, for his
Sure.
work in vaccine delivery in rural Kentucky. I didn't know if you know that.
Yes, I did know it. He was very honored that.
Yeah,
Yeah,
he spent a decade doing that. I really am proud of him.
yeah. I was a member of the KPHA for years and years. Of course, I let my license expire when I didn't really need it. But
Yeah,
but
I did the
sometimes
same thing.
some
Don't feel guilty. I did the
yeah,
same thing.
I know. I knew you did. But sometimes with pediatrics, I wondered, well, maybe I ought to go back and do that. Did you see where the Kentucky College of Pharmacy is now going to do the registered pharmacist again, or at least the BS pharmacy degree again, so that they can do certain? I thought that was finally kind of a retrograde thing, but
Hmm. I didn't know that. When I did it, it was like the difference was maybe 3 or 4 or 5 months. I was at the very end of that. That started about 1985. And they were getting the same jobs. It made really, at the time, it made no sense to go forward unless you just wanted to put a particular credential beside your name.
yeah,
Now that I think has since really changed, but I was right on the cusp of that.
right. I understand. Well, it was interesting. Chip is it Chip Guy, who's the dean, kind of
Yeah.
announced that, and then announced his resignation because he's going to Minnesota or somewhere.
Yeah. It's kind of I'm trying to think. It was after Dr. Dean Swintowski, and there was kind of a transition in there.
Right. Well, we certainly have enough unknowns with Medicaid right now. It's going to be, I twice a day I check to see what's going on and
Yeah,
where the latest in the big beautiful bill is. And
it's dynamic. It changes by the hour. It seems
yep,
like.
yep.
Good morning, this is Erin with the Department of Medicaid. It's not quite 10 o'clock and we're still clearing the waiting room, so we'll give it just a moment before we get started.
Hey, good morning.
Good morning.
Let's see, Georgine, do we have our quorum yet? We have Dr. Neal and myself. I'm kind of looking around here.
I think you two gentlemen are the only ones of the of the committee.
Okay. The ox is slow, but the earth is patient.
Yeah, Dr. Tran just sent me a email. I think he might be having difficulty signing in. So I'm trying to help him out with that.
Morning, Cody. You hear us?
Yeah, good
Dr.
morning,
Neal.
Dr. Bill.
Yeah, morning.
Good to see you.
Yes, good to see you. Can you see me? I'm seeing this technical advisory committee on my screen now, the agenda of what I'm seeing. So anyway.
Cody, Dr. Tran is on his way in. So it looks like he's logging in now.
Great. Thank you for letting me know.
Looked like a line of storms was moving through Kentucky this morning. I pulled up Owensboro's weather and they said they were under a tornado watch or something. So I guess there's a line moving through.
It's hitting Woodford County now.
Oh, okay.
I'm hearing storming outside my door. It's storming here.
Okay.
Hey,
Well,
Eric,
I'm in.
can you hear us, Eric?
Yep.
I don't know if he can hear us yet.
I'm in Port St. Lucie, Florida, and we hadn't had rain in 8 weeks. We finally got a storm and some rain 2 days ago, and the St. Augustine grass has finally decided to grow. But it's been really a drought down here.
Hey, good morning. Can you all hear me?
We sure can.
All right. Yeah, I got you all. Thanks.
Dr. Gupta's also on her way in from the waiting room. And then your waiting room is clear. So you do have a quorum, and I will hand it over to you, Dr. Thornberry.
Are you ready, Sarah?
Yes, we are clear from the waiting room. You do have a
All right.
quorum.
Thank you. Good morning, everybody. I'm Dr. William Thornberry. It's now 9:02 Central, 10:02 Eastern Time. This is the Kentucky Physicians Technical Advisory Committee. We meet under the auspices of Title 19. I want to address our quorum, Dr. Gupta, our MAC representative, and Dr. Neal, our Chair Emeritus, Dr. Tran, Dr. Leiden, and myself are all here today, and that will meet our quorum. Our first effort is to review and approve the minutes from our previous meeting. Do any of the members have any comments, additions, deletions, or suggestions, or can I entertain a motion to approve those?
So moved.
There's our motion. All in favor?
Aye.
Very good. Yes, with this, we do not require a second on that. Our old business, the first item I have up here is 907 KR 3005. Cody, before I get into that, I just want to let our members know that we do have a 90-minute meeting today. As I'm sure all of the executives here can appreciate, the spring and the fall, everybody wants to have their meetings and they all want to be on the same day at the same time. So we have 90 minutes and we'll be cautious about addressing our comments and our work today. Cody, can you set this up for us and let's get going?
Sure. So at the last Physicians TAC, I know it's been a little bit of time since then. It was at the end of towards the end of last year, but at the last meeting, there was some discussion regarding this regulation, and it's specifically in reference to the language in Section 4, subsection 7 of 907 KAR 3005, which states coverage for an evaluation and management service shall be limited to one per physician per recipient per date of service. And it had previously been shared when you all had discussed this prior, that this specific language had created a lot of confusion and difficulty amongst practices, both in terms of billing and providing care over the course of the last year. And even just recently, as of February of this year, there have been some issues. There's been at least one MCO that has pointed to this regulation or this section of the regulation as the basis for recouping claims where there was a sick and well visit billed for the same patient on the same day. And there have been multiple practices that, at least at KMA, that have reached out to us and shared that they have had a significant amount of claims impacted by this. And so it's really created a lot of strain on these practices in terms of cash flow, providing the appropriate care when the patient is in the office at the appropriate time, as well as billing confusion. Because as far as we're aware, you have the other MCOs that are largely allowing for the two codes to be billed with the modifier 25, and then at least one that does not. So the inconsistency has caused much of the issue here. But it's also a section of the regulation that has gone unchanged for quite some time. And so since the last physicians TAC meeting, there had been some discussion amongst all the MCOs regarding their policies. And the feedback that was shared from that was that the majority of the MCOs had policies that went beyond what the regulation allowed for. And those policies are in line with the national CPT guidelines, which advise that in situations where multiple E&Ms are necessary, both codes are billed and use the modifier 25 to establish the distinction. We also have had some conversations since the last TAC meeting with DMS about this issue, and where that was left was DMS was going to discuss the policy with the MCO CMOs, as well as pull some additional data and take a look at what other states' policies were on this issue. And so that's the brief recap of the issue, kind of currently where it stands. Dr. Thornberry.
Thank you, Cody. I would like to address the why behind this before I open the discussion. I think, as I see it, I think all the honorable physicians at all of the honorable health systems want to be compliant with Medicare's correct coding initiative. And with that, we're trying to fully document what it is that occurs in the actual encounter. With, for example, many specialties, you come into nephrology, you have stage 3 chronic kidney disease. We're going to talk about that. And then we're going to go on to the next patient. In primary care, the role of primary care and the charge of primary care is a little different. Part of what we do is we provide in the health system, we're the people that actually provide the preventive medicine. And so in the long run for the MCOs and for our Commonwealth, we're trying to mitigate substantial expenditures in the long term by providing the wellness and the preventive care. So that's one charge. Another issue is we provide chronic disease care. We provide the overwhelming majority of chronic disease care. That's another charge. The third thing is we provide acute care. Again, that keeps people out of the emergency rooms and urgent clinics where it's really not appropriate, in my opinion, for our value. I think there's a better value and a lower cost to try to address these in a better venue. And so when you're asking a particular service to conduct 3 roles, then I can just think of it happens on an hourly basis. And, we'll have somebody in, we have them in the office. A lot of these people cannot get, particularly with these underserved areas, it's very difficult to get them actually into the office. And, from every 10 patients we schedule, maybe 3 or 4 of them won't show up. And, if they ever leave, it's hard to get them back. And so a lot of times we will take a bird in the hand as opposed to, one in the bush, because we have them there. That's our philosophy. We're here to try to mitigate in the most cost-effective manner the needs of that patient so that it doesn't get into a more of a substantial problem. And I think what we're trying to suggest is the 2-5 modifier helps us in the current structure of CPT to explain what it is we're doing. Now, these clinics and health services are taking liability. They are taking time to document, and they're providing the service. And then that a lot of times is not seen in the actual schedule. It doesn't show up on the schedule because, you know, they'll come in with one thing and you get the by the way thing. And you're like, well, do I address that now or do I address that later? And some of these things, you know, are better addressed up front before they become significant problems. And to me, that is the why behind this. Let me kind of open the floor up to our membership. And then I certainly would like to bring our MCO partners in on this as well. Who has some thoughts on this?
Dr. Thornberry?
Yes,
I
Dr.
like-
Trey.
Yeah, I like to segue into what Dr. Thornberry has just commented, and I similarly agree. I also want to point out that I'm also looking at it from the patient-centric perspective. For many of our patients, we all know that transportation is one of the most significant barriers to healthcare. And to ask these patients to make frequent trips is quite a burden. And so from that vantage point, if you've got them here in your office and they have another problem and you can handle this problem, but maybe another provider can handle this problem, go ahead and have that person taken care of right there and then. So for example, in our practice, we manage mostly addiction. The patient comes with addiction. And by the way, I've been having this cough and it's making me short of breath. And you know what? We have a semi-urgent care type clinic over here. Dr. So-and-so is on duty for that. Why don't we have you see Dr. So-and-so over there and take care of this instead of having the patient make another trip to an urgent care or the emergency room for that visit. So from my vantage point, I think that we have to look at the perspective of the patient's access to care. Many of my colleagues complain they have the patient scheduled to do a procedure on the right elbow. And by the way, can you look at this thing on my left leg? Well, that's a separate problem. And, you know, no, you have to come back another day because I can only see you for this problem today. I'm doing this procedure on this problem today, and you have to come back another day to have the second one taken care of. I think that's a significant burden and hindrance to the patient's care.
Dr. Neal, I'd like to speak to it briefly, Chuck, if I could. You know, as a pediatrician, preventive care is our major goal, and it's becoming more and more difficult to get the patients in for preventive care, which is primarily immunizations, growth, et cetera, and social determinants, obviously. But what we're seeing is that many of our visits are initiated by an acute illness in the child, and rather go to urgent care or the emergency room, they call our office and want to come in. We find that they're behind on a preventive visit. So obviously we really need to do both things. So it takes enough time now to do the well visit, but then to address the illness, which for most children is not the chronic illness as much as it is the acute illness, whether it's an ear infection, whether it's croup, whether it's flu, whatever. And we have to address that issue, which often leads to laboratory. It also leads to prescriptive medicines also. And so those two issues have to be addressed, both well and sick. And I'm reviewing the charts of our pediatric patients for the group that I work for from Florida to California to Arizona to Connecticut. And I can tell you that that's being done at many, many visits by our pediatricians, and it's being paid by most of the MCOs because most everybody is out there. So I can tell you that it's so important for us in pediatrics to have those services, because if we just get the charge for the well visit or just for the sick visit, it just simply does not take care of our costs. So I'll stop there.
I'd like to, if it's okay, I want to get everybody's perspective on this. And in particular, I'm most interested in Dr. Terrio's work. Judy's been out front on this topic. Dr. Terrio, can you hear us? I know you're on the call. I'd like to bring you in here. I really would value your wisdom on this.
I mean, I agree, being a pediatrician as well. A lot of times you have to do 2 visits at the same time. And we have been working on amending the regulation for that. And I believe Jonathan Scott is on this call. And we've amended the regulation. I don't know where it is in its journey, but it will be fixed.
Well, I certainly, one of the things that I want to point out is we have to look at this from everybody's point of view. And the point of view I don't want to miss is our MCO partner. You know, they have a budget. They come in a very generalized way to try to provide a certain amount of care and try to provide that effectively and efficiently. And I think this whole thing doesn't really work. I see it from the patient's point of view. I understand the provider. Obviously, I see it from the health system's point of view with scheduling and missing claims. But really, from their point of view, is if it doesn't save money in the long run for us, which is what this whole thing's just designed to do, then it really is not functional. You know, it's just a one way to move beans from one pocket to another. And that's not the intent here. The intent here is to try to run a more efficient system so that in the long run, you look at 1 year, 3 years, 7 years down the road, that making these implementations, it will save us money and it will save real money that we can see. And I would encourage and invite any of our chief medical officers or any of their representatives to chime in on this. I'll be very interested to see how they see it.
Hey, Dr. Thornberry, it's Sarah Moyer from Humana. I mean, we
Hi,
agree with
Sarah.
you. I mean, transportation is a huge issue in Kentucky. Any way we can do to get our members into the office and treated while they're there. And it also helps on the continuum to value-based care too, right? Like we don't care how many office visits they have as long as they're getting treated. It does sound like maybe it's just a one MCO issue. And so it sounds like it's getting fixed too. So I don't know which one that is, but would just suggest maybe some one-on-one conversations.
And this is Herb with Humana for claims operations. And, you know, I want to add that the regulations are out there about, you know, about the same services on the same day that is not covered per the regs. And they don't address modifier 25 being an option to use to get around that. Now CMS does, and that's put out by CMS. And I think almost all the MCOs, I'm not sure which one it was, but I'm pretty sure that almost all the MCOs are utilizing that modified 25 to show as a separate and distinct treatment on the same day as another one. And I know we do.
Well, we appreciate that. Thank you for your thoughts.
Don Neal, can I just interject one thing here?
Yes,
We
Dr.
and Sarah and I have debated this point for several years, I think, but we're transitioning from treating sickness to treating wellness, and treating sickness saves money in the short term, but treating wellness is a much longer treatment. And so to save money with wellness takes a long time. This is discussed, and I think we've talked about this a lot, but I just want to make that brief point.
Yeah, I don't think anybody would disagree, right? That preventative care in the long run is the most cost-effective way for our members. So
good.
This is
Leslie?
Kelly Kitchen. I'm the branch manager with physical health, and Justin isn't able to be with us today, but I do want to let you know that we are addressing your concerns, and we are submitting a request to have the regulation updated to legislation. We don't have a time frame as to when that will be complete, but we are in the process of sending an updated regulation for approval through legislation.
Thank you, Kelly.
You're welcome.
Hoffman, Dr. Tishman, do you have any thoughts on this at all? Or are we just kind of repeating ourselves? Dr. Cantor?
Good morning. This is Jib Teichman.
Hey, Jib.
How are you all this morning? As a pediatrician, I also support taking care of all problems when you're face to face with a patient. Not sure if we're the one MCO that you're referring to. I know this has been an issue with some of the practices I've talked to, and I know that we've taken steps to honor modifier 25 since the first of this year.
Well, let me say for everyone here that I think what I don't want this to feel like is we're trying to shame one MCO into reconsidering their work. The point of it is, I think, is we're trying to suggest is, well, how pervasive is this and what's the current opinion? That's not what this is about. I think we all have the same goals. And here we're just trying to be as reasonable as we can and try to get all viewpoints on the table. I'm not here to disagree with anybody, but if we can't understand, if there's a problem that we can't see or a problem that we don't understand, that we certainly can't address that. And that's not the point of our shared work together.
Hey, this is Chirag Patel. Can you guys hear me?
Yes, Dr. Patel. Welcome.
So I very much agree with my CMO peers as well. I think you should get all the care you can in one instance. However, I would be remiss if I didn't give you the converse or the alternative, right? 100% of all pediatric visits don't have to have a sick visit attached, right? And so if we were to see a given provider overnight start to have 75, 85% of their visits under certain circumstances, it would draw attention to that personal practice pattern. And so I just want to make sure that while we give everybody benefit of doubt, doing everything in the moral interest, in the clinical interest of the member, that is not always the case.
Yeah, I think everyone here understands that.
This is Jeff Teichman again. One of the things I've seen with the use of modifier 25 is the use of modifier of a well visit with a high level E&M, like a level 4 E&M. There's a lot of overlap in the correct coding of a well visit and a 99214. And it's hard to rise to the level of a 99214 or 99215 with a checkup. I have seen some practices exclusively coding modifier 25 with the well visit and a 99214. And you'll have to agree that when you're faced with a child, for example, who's there for his 6-month-old checkup and has an otitis, that does not rise to the level of 99214.
Dr. Neal, I would agree with him. I review charts daily, and I can tell you that we have to look at the coding, which can be difficult. Sometimes it gets tied to RVUs, and that bothers me because I get the feeling that we're attaching that because of what it gives us in remuneration, and that's troubling. So I agree with you.
I'd say that I would have to agree with that too. That's although I don't, my part of I don't practice pediatrics as part of my practice. I think we can all agree on, again, I think using correct coding initiatives to be honorable about coding and be honorable to the patient is all we're talking about here. I don't think we're trying to, and I don't support things that are inappropriate or, yeah, that's not the work we're trying to accomplish here. Well,
Dr. Thornberry, this
yes,
is Dr.
ma'am. Yes, Dr.
Hi
yes, Dr.
there.
Cantor.
Hey, good morning. Sorry, I'm in the car, so I apologize for any background noise. I agree with everyone's comments from all sides of this perspective. The only thing that I would add is if there are specific examples that could be given to us or to the MCO that has this going on, that is super helpful in being able to understand how it's being picked up from our claim system perspective. Maybe it's something, I don't know if it's us. I don't think it's us, but I don't know if it's us. But I would welcome examples because maybe it's some switch. I can't explain everything in claim, but things like that happen. So I'd welcome examples. Thank you.
Well, I would turn my eyes to Cody. Cody, do you think KMA can help us? And again, with Dr. Neal's experience, particularly with his audit review, maybe we could work with Dr. Cantor and our other MCO partners to try to provide some concrete examples of what this might look like, what would be appropriate, what would be not appropriate. Can we work on that?
Yeah, sure. So like I said, it was just one MCO that had the specific issue tied to the regulatory language. And And we have had conversations with varying levels of staff within that MCO regarding the issue. I think the first time it happened, it did get relatively resolved. But then there was an instance earlier this year, and I don't know ultimately how that practice found resolution with the claims that were affected this year. But certainly can follow back up with the MCO.
Well, I hope that, and it appears to me that we're generally of like mind, that we want, again, what's the most cost effective in the long run for the health system. We are trying to respect the values of the patients. We understand the health systems are trying to do things efficiently. And I understand, again, intimately well, being a provider, when it's like to be in front of that family. But I think here we generally are looking at have the same shared vision. So if we could work toward that as our next step, would it be appropriate to move this from this part of old business into our recommendations at the end of the meeting? Do the members want to do that?
Yes, I think that's fine, Dr. Neal.
Okay. Well, we could bring it up at the end and kind of move that into your basket, Dr. Gupta, if that's okay. We'll look at that at the very end. Cody, if I can, unless there's are there any other new ideas on this topic? I don't want to exhaust it, but I think if it's not, I'll probably move us into new business. If we have Angie on today, I'm kind of looking in her direction. Cody, if Angie's here, could you set this up for us, please?
Hi, this is Angie Parker with Division of Quality and Population Health, and I am on the road. So I am on my phone, but I do have some staff, Troy Sutherland and Leanna Trainer, who will be presenting regarding the VBP and quality initiatives that we are doing.
Right.
But before I get
Cody, let's do this. Angie, before you jump in there, Cody, would you set this up for the members that may not have been present or be unfamiliar with that work before Angie and her team pick this up, please?
Yeah, sure. So last year, and I think maybe even the year prior, I believe 2023 to 2025 is the implementation timeframe that Angie and her staff will be referencing. But the physicians TAC had some discussions previously on the quality measures and the value based efforts that were being established by DMS to improve the quality outcomes. And so there was some curiosity at kind of where that stood, and just to get an update on that work here today.
Okay, and like Troy Sutherland has a little PowerPoint that he is going to present and give you an update on that. I will say, and this is part of the presentation, that the value-based purchasing program with the MCOs officially started January 1st, 2024, and it's based on HEDIS measures. Therefore, we are still getting the final results of the 2024 measurement year. So we don't have that yet, but I'm going to turn this over to Troy in just a second, but I do want to address the previous topic that was talked about. So if there are continued issues with this MCO, please bring those to the DMS, and there is a provider inquiry email box that you can send. If you continue to have those types of issues, we would certainly like to look into that ourselves. So with that said, I am going to turn it over to Troy.
Thank you,
Thank
Angie.
you.
Hey, Troy, can you hear us?
I can. I'm sorry about that. I'm trying to get my screen shared. Can you guys hear me okay?
I see you, and we hear you.
Good deal.
Good luck with this, buddy.
Yeah, I'm not. Can you see that presentation?
No, I'm not seeing it.
Okay. Good deal. How about now?
Yes.
We can, Troy.
Perfect.
Does everybody see
Okay.
it?
I see it, Dr. Neal.
Can you see it? Good, good. All right. Success number one. Thank you all. And good morning to everybody. As Angie mentioned, my name is Troy Sutherland. I'm the Quality Branch Manager in the Division of Quality and Population Health. And just want to give you, go through this brief PowerPoint to give you guys an update on where the VBP program stands, and what we're working on currently with quality initiatives and some of the reporting, I guess, timelines for this year for the VBP. Okay. Good. All right. So the value-based payment program, the VBP model aligns incentives for enrollees, providers, MCOs, and the Commonwealth to achieve Medicaid program goals and access, outcomes, quality of care, and savings in alignment with the 2023 to 2025 Medicaid managed care quality strategy. The managed care organizations will be incentivized through the VBP program, and the payment strategies are tied to achievement of the outcomes. The program started on January the 1st, 2024, and we will see the 2024 quality measure results reported to us this fall. We'll likely see that reporting the first or second week of October. That's normally when we get that reporting in. So the MCO VBP program design, there is a 2% withhold from the total contract value. There's six core quality performance measures plus a bonus pool for eligible MCOs. The MCOs must achieve a 3% or 4% point improvement to earn the withhold dependent on current performance. They must earn the withhold on 4 core measures and maintain performance on all core measures to be eligible for the bonus pool. The scoring for basically the MCOs, this is a pass-fail. There's no partial credit with this. There's no withhold earned for missing the 3% or 4% minimum improvement. And as I mentioned a minute ago, those HEDIS measures, we will get that report from our external quality review organization, very likely first or second week of October, and then we can evaluate the MCO's performance at that time, looking at those the measurement year for 24. Let's see. So just to go through the VBP core measures, either the 6 core measures, we're looking at the HBD good control, it's HbA1c less than 8. That's the percentage of members 18 to 75 years of age with diabetes types 1 and 2, whose hemoglobin A1c was measured to be in good control during the measurement year. Postpartum care, that's the PPC measure. The percentage of deliveries that had a postpartum visit on or between 7 to 84 days after delivery. The child and adolescent well care visits, 3 to 21 years of age. The sum of stratifications total, that's the WCV measure. That's a percentage of members 3 to 21 years of age who had 1 or more well child visits with a PCP or an OBGYN practitioner during the measurement year. There's a childhood immunization status, that's the CIS Combo 10 measure. That's the percentage of children 2 years of age who had a combination of 10 vaccines by their 2nd birthday. Immunization for adolescents, that's the IMA Combo 2 measure. The percentage of adolescents 13 years of age who had 1 dose of meningococcal vaccine, 1 dose of tetanus, diphtheria toxoids, and acellular or pertussis vaccine, Tdap, and 3 doses of the human the HPV vaccine, their 13th birthday. I practiced that too. Sorry. Vaccine by their 13th birthday. I'll note that the HPV piece there is it's report only for the first year. We recognize some of the difficulties in getting children in place to take all of those vaccines. So we decided for report only on that specific piece. Social needs screening and intervention, the SNSE measure. The percentage of members who were screened using pre-specified instruments at least once during the measurement period for unmet food, housing, and transportation needs, and received a corresponding intervention if they screened positive. And again, for this one, this is report only for the first year. I think that that was a newish measure when we had decided on that. And we decided just to make it report only for the first year. let's see, the bonus pool measures. There's 4 of these. Metabolic monitoring for children and adolescents on antipsychotics, the APM measure. It's a percentage of children and adolescents 1 to 17 years of age with ongoing antipsychotic medication use who had a metabolic testing during the year. The follow-up after emergency department visit for alcohol and other dependents. It's the follow-up within 7 days of an ED visit total. That's the FUA 7-day. That's the percentage of emergency department visits for members 13 years of age and older with the principal diagnosis of alcohol or other drug abuse or dependence who had a follow-up visit within 7 days of the ED visit. We have the weight assessment and counseling for nutrition and physical activity for children and adolescents, counseling for nutrition total. The WCC measure, that's the percentage of children and adolescents 3 to 17 years of age who had an outpatient visit with a primary care practitioner or OBGYN during the measurement year and had evidence of a body mass index percentile documentation, counseling for nutrition, and counseling for physical activity. And lastly, breast cancer screenings, the BCS measure. It's the percentage of women 50 to 74 years of age who had at least 1 mammogram to screen for breast cancer in the past 2 years. And just to move on to, just to give you an idea of some of the current DMS quality initiatives and the activities that we're working on currently. We have a tobacco cessation performance improvement plan with all the MCOs that launched on January the 1st of this year. I'll note that those performance improvement plans generally it's a 3-year plan and looking at performance improvement. We submitted our 2025 annual technical report to CMS this past April. They do require an ECPRO generated report that with many different focuses the CMS requires. That's due by April 30th of every year. We've gotten that submitted. A couple of focus study developments that we've been working hard on. We're looking at continuous glucose monitoring and one looking at community health worker focuses that will launch later on this year, probably I'd say July, August, I believe is when we'll get those kicked off. We're just about finished up with the development of those, excited to get those started. We've been working on a breast cancer screening PIP that is going to launch July the 1st. There is a little bit different time frame for this one. Like I said, normally these PIPs go for 3 years. This one will actually be a 4-year PIP. There's a couple of new performance measures that'll get started sort of during once the PIP gets going, and so we've added an extra year to include those. Again, we're excited to get that one started and really try to improve some breast cancer screening efforts in the state. There's 2 focus studies that were began last year. That are currently in review. One of those has been reviewed by us and is in the hands of the MCOs right now for review and comment. And we will, the other one we will be getting from our external quality review organization very soon. And that's the disparities in postpartum visits, 48-hour ED revisits, maternal morbidity and death during the 12-month postpartum period among Kentucky Medicaid managed care enrollees with a live or non-live birth delivery. And lastly on that one, the disparities in emergency department visits among all Kentucky Medicaid managed care adults and follow-up care for adults with multiple high-risk chronic conditions. And then moving on to give you an illustration of some of the quality reports that can be found at the below web address. We do have some work to do in getting some of those updated and getting the most recent reports out there. But it gives you an idea of some of the reports if you're so inclined to go out there and look through some of these reports, some of the access and availability surveys, and those are out there that looks at using secret shopper surveys with different provider types to sort of gauge and access members' ability to make timely appointments. We have a comprehensive evaluation summaries. And I don't note specifically on that one. Again, if you're so inclined to go out there and look through those reports out there, there's two really good ones that I would recommend to start with. One of those being the comprehensive evaluation summaries. The 2025 report is getting ready to be finished, and we'll get that posted out there. And also the annual technical report that's already out there for 2025. They're large reports, but they're very comprehensive. And I think they explain quite a bit about the efforts from a quality perspective that we are engaged in, really month to month and year to year. And they're just really good reports out there for giving good explanations, I think, and really highlighting those pieces. All right, that's all that I have. Any questions from anybody on the TAC today? Welcome those.
Yes, I have a couple of questions, Dr. Neal. Can you go back to your first graph there that had to do with the value-based? First one, right out. No.
Right there?
Right, no, go to the next one.
Okay.
Yeah, right there. Okay.
Mhm.
First, I might say very quickly, we're about 30 years late getting this done. Okay. We started with something called KenPAC for about 14 years. That was 30 some odd years ago. And we were trying to just help access to care, if nothing else. And we were trying to get what we didn't call value-based things. We were just trying to get measures, HEDIS measures put in that would assure that children would both have access to care and that physicians would be able to make enough income to see Medicaid patients. And it was ultimately decided that we didn't increase access to care or save money, so that KenPAC was done away with. But I don't understand why on child and adolescent care, why are we not saying it was the reverse before? We wanted to see 5 visits up to 15 months of age, well visits, because we thought those were the most important, because those are the ones that led to the next item, which was childhood immunization status. Because we could get them in, we could get them vaccinated. And I don't understand why, because those later visits, 3 to 21, although important, are not nearly as important as the first visit. So I'd like your comment on that. And I can tell you right now, pediatricians are just begging parents to get immunizations at this point. So I can't tell you how almost needs to be a bullet there, time spent debating with parents about immunization. So I'll stop there because I could go on forever and ask you to comment on that.
I think it's a lot of it is that we, if you've noticed with a lot of these measures, I think we've really tried to focus on some of the things I think that maybe not uniquely affect Kentucky, but just some problems or some issues that have been there for Kentucky for a long time, like the diabetes piece, the focus on women and children. And it was really determined that we were going to look at a total of 10 measures. And we felt like that the measures that we had chosen for this, I think had the most opportunity for improvement and bringing to bear all of the expertise and the efforts of all, at the time, 6 MCOs, now 5, obviously. But I think that that's sort of the thinking that went in to choosing these measures. We could have had 20 measures probably, but I think for ease of measurement and for keeping it, I don't want to say as simple as possible. Previous efforts with VBP, I think, were really complicated, calculating things. This was certainly before my time, but some of the information that was shared to me about previous efforts with VBP is that it was just cumbersome and it was hard to calculate. It wasn't entirely successful. So I think going into this design, I think that's what we were trying to look at: women and children, diabetes, and having measures that we could get reported on every single year that would certainly make the biggest impact for our members. Did that answer your question?
Yes. Well, still the question of why did it get picked of 3 to 21 versus the other, I still would debate. I wonder other pediatricians if we would comment on it, I'd appreciate it.
Well, just before we get to that, this is Angie again. Regarding this is a HEDIS measure that is determined by the National committee of quality assurance. And the definitions for that is through the years, and they make changes as they see necessary. So that is the reason why that particular measure is defined the way it is. If
Okay.
if that's answers your question, why that measure is defined the way it is.
Okay.
Thank you, Angie.
I have a question, Mr. Sutherland. This is Ashma Gupta. These are all measures that the MCOs are ideally supposed to achieve, correct?
Yes.
So is there a pathway in place for them to achieve this? Or is it just they just come up with their own plan, each MCO?
I think that it's really, I think, how they want to approach it. I don't think that we don't dictate to each of the MCOs and how to do it. I think they all have plans in place already. Before really the creation of the VBP on how to address, whether it's vaccinations or whether it's well child visits or whether it's postpartum care, and I think that by really us focusing on this, I think it allows the MCOs to just strengthen their already in place, processes to ensure that they hit those percentages and potentially get that withhold back. But I think we allow the MCOs to really chart that path.
One question about the immunizations. That's already been a tough situation, all these years. But now with the misinformation from the federal government, is there something that DMS along with the MCOs could provide to try to, along with I know the American Association of Pediatrics is already trying to put things in place, but just like give more education about the truth about immunizations, because I feel like that is something that is it's already becoming so difficult. And
Yes.
so,
And that's one of the excuse me for interrupting, but yes, we understand that, and that's one of the reasons why we have the immunization measure that we're looking at. I mean, we know that there was an issues with children getting their vaccinations during COVID, and then so we needed to ramp that back up and went into anything communication wise that our providers can include in their visits. We know the challenge that you're receiving, the people just say no. The MCOs are doing education with the members and the providers as well. We are working with public health on an HPV. I can't think of the word right now, but getting the information out on HPV and the importance of those of that immunization or vaccination. So there is a lot of work going towards that. And I think it takes all of us to get the right information out when the wrong information is coming out from our federal government.
Dr. Neal, again, a quick comment. This is basically for the MCOs. Then the MCOs have to then work with their clinicians or their primary care providers, if you would. I hate that word. But anyway, I don't want to see this get into a punitive situation, because we're all in a war right now trying to make this happen. We're all in this together. And it's to the advantage of the MCOs and we, the clinicians, to make these things happen. And it's really difficult. So I hope we're not going to get into a war between the MCOs and the clinicians. I hope you understand that, and how do the MCOs feel about that? Because you're putting this onto the MCOs, but then they have to, that really only happens if it happens to the primary care physicians. You understand what I'm saying? Okay.
Yes, sir.
I do. Yep. Go ahead, Angie.
And I think it's for the betterment of your patient, right? So yes, I understand that the MCOs can do value-based contracts, and I think they do a lot of that with primary care because we're all working together to make sure our children are getting preventive services, that our diabetics are getting the care that they need, that our maternal health patients and enrollees are getting the pre and postnatal care. So this is where and why we are doing what we're doing. And it takes all of us. And I appreciate, Dr. Neal, what your concerns are, but we're hoping that with all of us working on this, that we will get our children vaccinated, that we will get our diabetics under control. So it takes time, just like Troy was talking about with the performance improvement plans. It's 3 years when looking at those. So it takes a while, and you have to start somewhere. And this is where we decided to start with this value-based purchasing program. The MCOs were already doing quality initiatives in a lot of these areas. It's just that because there's a lot of the numbers that we all know are not where they need to be in the state of Kentucky or elsewhere, probably. But we are targeting our children, our mothers, and chronic conditions, and where we can, because we can't boil the ocean as much as we would like to. But this is where we're starting.
Can I make a comment, Mr. Speaker?
Of course.
So I agree with Angie. We can't boil the ocean. And the MCOs, we don't always agree on everything, but we do agree on this. Like, this is a great place to start. Now, are there some things within the metrics and the administration of the program that we can improve on year over year? Yeah, it's a journey, right? And so know this, that the MCOs are working together through the KPCA Quality Committee and the CMO Committee. We have a lot of dialogue about this. We interface with Dr. Terrio quite a bit about this, having back and forth dialogue. It's been constructive and informative. We do a ton of direct to member work, improving health literacy. We're in the schools, we're in the communities, we're in the congregations. Those are things that you guys probably don't necessarily feel or see from us, but there's been an immense amount of effort from the MCOs to push this forward and not push all the work back onto the provider, right? We also know that you're facing immense pressures of volume in your practices, and often are understaffed, or the construct of your practice is not conducive to managing all of this. And so we've tried to take some of that off your plate as well. So agreed, we're in this together. This is important work, probably the most important work we're talking about today. And we're all in it with you guys as well, even though we don't always agree on everything.
I have one more question, Mr. Sutherland. So if the MCOs do not achieve these measures, are they financially penalized?
Yes.
If they don't, yeah, if they don't, yeah, the withhold stays with DMS. So I think I could consider that a penalty.
And then if they're penalized, will the physicians or providers, be penalized downstream as well?
It's hard for me to comment on that. I would like to think not, or I don't know how that would come about. But that's just really in my thinking on that. That wouldn't happen.
It's dependent on what your contract is with the MCO. I mean, if you have a value-based purchasing program with the MCO, I think that would determine that. Now, if you don't have a VBP, no, it should not come down on the providers.
But I think in the end, it depends on the providers to get this done. And if they're not able to get it done, then, someone is going to have, in the end, the providers always end up taking the hit. But even so, these can be very difficult measures, although I totally agree with all these measures, and this is what we want, but a financial burden is just, I don't know, I feel like in the end, it's not going to help anyone, and it's very difficult to achieve. Be great to have a bonus, but, penalties just make things much more.
That is not the goal. We want the MCOs to achieve. We want to give them back their money. This is the ultimate goal for that. So, because everybody wins. And I can talk about quality all day. If you can tell in my voice, I get a little bit passionate about this because I am you know, I know everybody is trying to do the right thing. And sometimes other outside sources get in the way of that. But I appreciate your comment. And if that does come to fruition, then I would think that we could address that at the time.
Well, Angie, Troy, we greatly appreciate the effort of DMS behind this and making a little time in your all schedule today to kind of work through this. I just
Dr. Thorne?
intellectually, I can't help but foreshadow that, you know, with continuous glucose monitoring, when selected for the correct people, how much of a dramatic change I've seen in people that were just completely used to be, you could not control them. No matter what you did, you really couldn't get buy-in with them. You know, they just, for a number of reasons that really weren't the provider's fault, they just had no influence. But kind of getting the patient seems to be, at least in my abstract sense, is trying to get them involved with that has really made a difference when we select the patients correctly. Do I think it's necessary or even recommended for everybody? Absolutely not. You know, not the current cost structure, but they're the right people. It's really made a difference. I'm very interested to see how that data comes out over time.
Well, let me just tell you, Dr. Thornberry, we have been working with the Center for Healthcare Strategies in the last year and a half. And I don't know if Letha Harris, she's my branch manager for population health, where we are doing all kinds of work regarding CGM. So I'm so glad you brought that up. And if you would like for us to talk about that at the next TAC, we would be more than happy to.
Well, there's a couple of things I'd like. I definitely, well, I mean, I have an intellectual curiosity. I did general surgery and I was boarded in family medicine, but really I'm really a kind of a functional internist, and I really run a chronic disease clinic. So I'm very, very, very interested. And I like the current date, you know, the current line that's using, you know, the metadata for the internists say that over 8, you're going to have problems. Below 8, you're not going to have problems. So to answer your question specifically, yes, I would welcome that if it's not too much work on your guys' end. You know, I'd like a brief presentation. And another thing, you know, Cody, I see kind of Jonathan's kind of meandering in the background here, but in 4 or 6 weeks, could you just kind of put a little note to yourself to kind of follow up with Mr. Scott to see how he's doing and see where we're at on this on 907. I just don't want to lose track of it. I've kind of got it down here to the very end on it. But Angie, I appreciate, and Troy, thank you very much. I know you guys kind of getting called out today, but I think everybody on this call I think everybody here really has quality at heart. And my goal is to try to make sure that every partner in this trip together that we're taking benefits, because unless we all win and everybody gets a piece of this pie, it's not going to work. It's not going to be sustainable. So I think we all are really, hey, Jonathan, I saw you kind of hanging out in the background, bro.
Well, I can come and talk about quality anytime y'all want to. Troy and I are more than happy to.
Cody, could you negotiate that with Angie next time? And again, I do want, if it's okay, Jonathan, I'm going to have kind of Cody knock on your door in a little bit, okay?
Sure. And I was going to say, I have a presentation about the advisory committee changes we're making, but I know you all have some other stuff on your agenda. Did want to mention that we have a presentation that we can go over with that for you all as well.
We can do that next time. Is that okay, Cody? We're a little tight on time this time. Now, of course, Jonathan, in the background, we've been kind of keeping a pulse to that. I'll just foreshadow again. We have Dr. Gupta just kind of rolling off on the Mac, and Ashima, I want to thank you publicly for all of your hard work and your leadership on that. But we're trying to get people in place for that. But yes, sir, we would like that if that's okay.
Yeah. And we're accepting applications for the next 2 weeks. So by May the 29th, the new Medicaid Advisory Committee and the Beneficiary Advisory Council will be, we're accepting applications right now. Hope to have them in place. That's really all we need to say. But
we're trying to work with you on it. Yeah. But thanks, man. Thank you for the gentle nudge.
All
right. Cody, we have I want to move it kind of into item 6, which is our open discussion. I know Dr. Tran had brought some concerns regarding information that we had on the reimbursement for vaccinations and the physician's fee schedule. Dr. Tran, if you're still with us, do you want to set that up for us?
Yes. Thank you very much, Dr. Thornberry, and thank you, members for allowing me to bring this subject up. It's been brought to my attention that there have been some issues regarding retroactive disenrollment of patients who were previously verified as eligible and actively enrolled at the time of service. So the scenario is such. Providers who are taking care of their patients verify eligibility in the KYMMIS system portal to confirm that the patient is indeed active with insurance coverage. Provider then provides the services and is subsequently paid for services. Then the provider will receive a letter from Medicaid stating that the patient has been retroactively disenrolled due to patient being ineligible at the time of service. And this leads to recoupment of reimbursement. And my concern with this issue is this places tremendous amount of concern and financial problems for the provider. And this creates a lot of uncertainty in regards to patient access. If I as a provider am always worrying about whether or not my services will be, quote, recouped by Medicaid later, it makes it difficult to provide said services. So I can see all sorts of problems, and we did investigate this. And the explanation we received was that sometimes the Medicaid portal is not up to date. And it may state that the patient is eligible and active, but then it's not up to date and later shows something different. I hope that we can have members of our MCOs here address that question and issue.
Thank you, Dr. Tran.
Doc-
I want to make sure that we have it, that we understand the problem. Is there anybody else that can help us? I mean, I'm not sure that I understand it. I mean, it sounds like you're wanting the providers to be psychic or something. I mean, you give them a spot to go check. The person that they've checked on is eligible, but then kind of retrospectively, it's like, well, by the way, that data is irrelevant and we're holding you accountable. I'm not sure that doesn't make any logical sense to me. Am I sure that I understand this correctly, or is there another way to look at this?
Dr. Thorne,
Dr. Oh,
go ahead. Dr. Thornberry, I can tell you, I know of at least 2 pediatricians that essentially went out of business because this very thing. This is not new. It's happened. You can't be a psychic and know that those people are going to be retrospectively disenrolled. And so this makes absolutely no sense. And the problem is that you received these funds over long period of time, but the MCOs, or back then the insurance companies, wanted to be repaid, say, $100,000 in 2 weeks. So this is the kind of thing. So this isn't new. It's continued.
Dr. Thornberry, this came up in one of our MAC meetings in the last few months. And what we were told is that there is like this confusion sometimes, or the portal's not up to date, and DMS, did take some responsibility for it and that they were working on it, but it's kind of like a, not a glitch, but just they know about it, but having difficulty fixing it. And I mean, this has happened to me so many times when I see babies in the NICU. I get paid and then I'm asked for recoupment up to 2 years later. And it's such a burden for the provider to try to recoup, or first to refile that claim. And I wish that the MCOs could work with DMS together on the back end and just give each other whatever money is due to the correct company, rather than putting that burden back on the provider. That is not our fault. It's an error on the insurance company's part, and I wish that they would just figure it out with whoever the correct provider should have been, or correct insurance should have been. So I mean, I just wanted to bring that up, and then I would love to hear from the MCOs and DMS.
Dr. Thornberry, Chelsea Agee has her hand raised. She is
Yes,
the branch
please.
manager for the
can't see it.
MCO
I'm about
contract.
to scream where everybody's here.
That's what
Please.
I'm here for.
Thank you.
Hi, yes, good morning. My name is Chelsea Agee, and as Aaron stated, I'm the branch manager of the contract monitoring branch in health plan oversight. So I just wanted to bring a little bit of clarity to this issue. And now Jordan Griffin, she is our eligibility and enrollment branch manager. I do not believe she's on. So I can't speak to some of the eligibility issues that were mentioned. What I can say is that a lot of these are tied to SSI approvals. So I don't know if you're familiar with SSI, but when they are approved, that goes back to the date that of their when they applied. So SSI can take quite a long time to approve members. And so when they do get approved, they go back to that original SSI effective date. And so that does change and can change their enrollment retrospectively. So what we have done for those particular cases, we actually have asked our MCOs as of April 1st of this year to not recoup for any members whose eligibility has changed due to SSI issuance. Behind the scenes, DMS has a change order that we are working on for our system that will eliminate this completely from happening. So you shouldn't, once that system change goes through, you shouldn't see that for SSI issued enrollment, you shouldn't see those recoupments taking place. If you are seeing any recoupments that have been initiated from the MCO April 1st to date, we would just ask, and I'll put our inbox email in the chat. But we would just ask that you please send those over to us. If we could have the actual copy of the letter that you received that explains the recoupment, what shows the date that they initiated it, et cetera, and that would be really helpful. And then we will follow up with the MCOs on those cases to ensure that they are not recouping money. Any money for one beyond should be returned to the provider until we can get this system fix in place.
Chelsea, thank you very much. If I may, for just a moment, I have because of the opportunities I've had in my life, I have a position of being in a lot of very senior meetings around the Commonwealth. This is probably the best piece of leadership that I've seen in about 2 years. And I'll tell you why. The point isn't to try to say who ends up with the stink bomb here, because the stink bomb is all of it. All of this is our responsibility. But here, what I see is here's somebody taking responsibility until we can get the smooth edges all worked out for all of us, because we have a system with humans in that system. It cannot be perfect. It's not going to be perfect. But this piece of leadership, really, I can see how the providers are trying to do the best that they can. And because of this current system that we have, because it's not a perfect system, they're being injured, and that injures our families. And then when the families are injured, the whole Commonwealth suffers. But my great compliments, Chelsea, to you, and more specifically to your leadership. And I hope that you'll pass that along. I just want you to know this is the best part of my day right now. Cody, is there anything else that we had on our open agenda that we had kind of brought up here in the last week or so?
Dr. Thornberry, I had a few more items on the agenda, if I could.
I'll try to get them in. I do have a very hard deadline at 10:30, which means I have to run another meeting.
You mean 11:30, right?
11:30 Eastern, 10:30 Central.
Yep. Okay.
Yes, sir.
So Chelsea, thank you for that. And similarly, we've had situations where the portal states that the patient is not actively enrolled, and we provide the services. The patient pays for the services, and then later we get letters from Medicaid that, oh, the patient was retroactively enrolled, and you need to reimburse all of those payments back. And again, we happily do that. However, it also creates a lot of accounting issues and problems. So I very much appreciate if you guys could take a look at that aspect as well. It would be really nice if we can do whatever the portal says is actually happening. The second thing, if I may, is I have a second item, and that is, with all of these issues related to the finance of many of our practices, the cost of labor, the cost of resources, the cost of office supplies, overhead, etc. We are getting quite a few letters from the MCOs stating that starting next month or starting this next fiscal quarter, we are going to essentially reduce reimbursements much below the Medicaid fee schedule listed across the board. And while I understand that the MCOs have to do what they need to do, but it's terribly difficult and challenging for the physician staff to burden this reduction. We are already having to look at the costs of labor, as I stated, the cost of office supplies, overhead, and then to get decreased reimbursement just adds on to the tremendous burden. And while I don't expect to have a ready answer for that, but I do wish that DMS could take a look at that so that we don't wipe out every practice that we have.
Yeah.
The next, go ahead.
Oh, sorry. I was just going to respond to that. Yeah, and I will take back for your first point, I will take back the enrollment question about not having any insurance and then it being added later, back to our eligibility enrollment team, and see if we can follow up with some more information for you on that piece. For the additional piece, I will say contractually, MCOs are afforded the ability to negotiate rates with their provider network. MCOs, they have that autonomy. And so I definitely understand and hear the concern about provider abrasion, and just, making sure that providers feel whole at the end of the day. And so I'm happy to take that back as well, and see if we can have some meaningful conversations with our MCO partners around those reductions. But just want you to know, I don't have an answer today, but I do hear you, and we will look into that.
And one third item that I really would like to address, and that is in our practice, we serve a very fragile population, the addiction space, and many of these people are on very complex medications that require drug monitoring, etc. And they frequently need laboratory studies to monitor the safety of the liver transaminases, etc., etc. And to make it worse, they are extremely difficult to get phlebotomy only because their veins are scarred down. And so we have to hire specific phlebotomists who are a little more experienced to do patients with scarred down veins. So we have two problems. One is patients rarely will go to an outside center to get their blood drawn. And then two, these guys are difficult sticks. And many of the MCOs are now telling us they are going to include the phlebotomy and all that into the office visit. And how are we going to pay for the phlebotomists who are specifically trained to do this to do this procedure if it's already included into our office visit, which is again we're complaining about. And so this just adds one more layer of burden when we're just trying to attempt to provide the best care for that patient. So again, I don't expect an explanation, but just so that DMS is aware of the situation, because I think it does place a lot of stress on our providers. I can only see the primary care docs who are trying to do the right thing, get their laboratory studies, get their metrics in, but the patient doesn't always comply with getting these laboratory studies done. So bundling this into the office visit, I don't think makes a lot of sense for us.
Okay, yeah, and this is actually the first that I've heard of this particular concern. So I've taken a few notes here, and I can follow up with also our behavioral health team, policy team, to kind of get some of their insight. Maybe additionally, Dr. Terrio, just so that you know, we have a full understanding of what the MCO's policies are, and we can ensure that, you know, that, because I would imagine that this is probably an exceptional type of scenario. So to include it on a per diem office visit for providers who may not even need that type of service seems a little odd to me, but I'm not a clinical person. But yes, I've written this down. I will take this back and again, follow up with some of the other points here as well.
Yeah, I believe the MCO in question is WellCare.
Okay.
And I return the floor to you, Dr. Thornberry. Thank you for the
Thank you,
opportunity.
Dr. Tran.
Thank you all.
Is before I want to move into the recommendation or item 7 on our agenda, but I don't want to go without making sure that I at least open the floor to see if there are any concerns or any agenda items that our MCO partners want to bring forward or want to nudge us on for next time. I certainly want to keep an open forum for that. Does anybody have any concerns or anything that we can address here in the time we have remaining?
Dr. Thornberry, I think there was one other question that you wanted to address during the open discussion. It was about the 2025 physician fee schedule and when it would be published.
Oh yeah, that was yes, I got lost in I thought that was one of Dr. Tran's 3. Has that been published yet? Do we know where we are on that, Cody? Or does anybody from DMS can kind of would they have that on the kind of off the cuff information?
Kelly Kitchen, would you be able to advise if it's been posted? I know they're in the process of posting some approved schedules. I just don't want to speak on which ones because I'm not positive.
Or actually, we do.
There you are.
Yeah, so sorry about that. The physician fee schedule has been approved and we are currently working the system changes and updating, working on actually getting all the updates made to the fee schedule. And as soon as that's done, we will get it posted. And I apologize, it is
That's okay.
taking longer
Thanks,
than
Kelly.
normal.
Cody, could you help us and work with Kelly so that we can get that to those interested parties? Would that be okay, Cody?
Yeah, I can do that. The reason the question got brought up, there was a couple pediatric practices that had some questions about what the rates would be for certain vaccines. And I know that I believe they had communicated to DMS and through the governor's office, a number of different channels about those. And so they were just curious kind of where that all stood.
Okay. Chelsea, is that kind of one of the multiple eggs in your basket here this time? Are you kind of Cody, do you need to look into Kelly or Chelsea on that? I just want to make sure we're following up with the right people for the right things.
Yeah, I can email Kelly.
Okay.
Yeah.
Okay. So, and then again, some of these items we may need to just touch on briefly, or if necessary, a little more extended with our next meeting. Just make sure that I don't get that off my agenda. Okay. That we fully extinguish the fire on all those. All right.
Dr. Thornberry, I do
Yes,
have one slide that I would like to share about a survey, and the survey ends at the end of this month. So if that would be okay, it's just a really quick.
Yeah.
Okay. Thank you, Aaron, for making me co-host. All right. Are you all able to see that screen?
Yes.
Okay, perfect. So I just wanted to announce a survey that Kentucky Department of Medicaid Services putting out for our stakeholders. This is in regards to the managed care and SKY programs. So this survey will be open through the end of the month, and you'll be able to access it by this QR code or the link at the bottom. I believe Erin will also be able to share this in her follow-up. So you can click on the link. But this is just for all stakeholders, so members, providers, sister agencies. This is just a way for us to engage with the stakeholders, to look at our MCO performance, just look at the program overall and make sure that we're all in alignment with our stakeholders about how we want to carry out our managed care and SCAP programs. So if you all wouldn't mind to share with your networks, the more participation, the better, because these results really help us drive how we structure our program. And that was it. So thank you all so much.
Well, thank you, Chelsea. I'll move us to 7. We have one recommendation before the TAC today. That being the physician's TAC recommends to the MAC that DMS amend 907 KR 3005 to remove the daily per patient limitation on billing for E&M services. Is there any further discussion or is there a motion on that?
So moved.
Okay. It will
Second,
require a
Dr.
second
Neal.
here. If there's no more discussion, those members of the physician TAC in favor of that?
Aye.
Any opposed to it? Without exception, then we'll move that forward into Ashima's care. Our next meeting is July 18th, same bat time, same bat channel, 10 a.m. Eastern time. I want to thank our MCO partners and the chief medical officer and their support staff. I want to thank Chelsea and Kelly and all the DMS colleagues that have supported us. And we had each of the members of the TAC here, Dr. Loudon, Shima, Dr. Neal, Dr. Tran. I don't think I'm missing anybody, but thank you all. I know it's a lot of time out of your schedule, but I appreciate you keeping us on time today. And I'm looking forward to our next meeting. We're adjourned. Thank you, guys.
Thank you.
Thank you. See
Cody,
you.
Cody, this is Erin. Do you mind to send the recommendation in writing for me? Just to make
Yeah.
sure I got everything perfect. Thank you so much.
Yeah, I can do that. I see in the chat, Dr. Tran had asked for Chelsea's email address. If
I have
Erin, if you
added
could
that
just-
to your follow-up email.
Okay. All right. That'll work. Thank you.
You're very welcome. Have a great afternoon.
Thank you, Georgine.
Thank you.
My pleasure.
See you. See you, everybody.